Okay, so we are on the heart lab, lab number 2. And what I'm doing is the blood lab, I started by going through the notes. Now that you know where the notes are located, you can do that yourself. Most of this lab is looking at models, lots of models and lots of identification, which initially makes it a little challenging, but after a while, you guys get really, really good at quickly, memorizing different structures and things. And most of this lab is that with some physiology thrown in there. So you can go through the notes yourself. Occasionally, I will refer back to the notes and I may toggle back and forth because there's some very good pictures that I use for quizzes and exams in the notes, in the PowerPoint notes that I've provided for you. And then within the course itself, there's some additional images that I go through, and identify what's on there and try to apply some questions, so you can prepare for quizzes and exams. Right, so first we're going to go through this, the lab guide that you've printed out or saved. So you have a list of everything you need to know for your quiz and exam. Right, so first we're going to, when we look at the models, we're going to identify all these different structures. And in doing so, you become very familiar with the heart anatomy. It is imperative that nurses understand that pathway of blood through the heart. There's nothing that makes you more crazy is when they have nursing students come back and they don't know structure to structure what the pathway of blood through the heart is. You have to have this basic stuff down. And if you do, then nursing becomes a lot easier for you. All right, so we're going to look at all these on the models. Don't worry. Heart anatomy, all the different vessels and the valves mentioned here. The heart layers, by looking at a model, we will look at the endocardium, or identify the endocardium, the myocardium, the epicardium. When it comes to the layers, I want you to know the tissue and the function. So the endocardium is the deepest of the layers. That is composed of simple squamous epithelium or epithelial tissue. So right in here, simple squamous epithelium, and then maybe a semicolon, says reduce friction, because that nice flat squamous cell is very good for the lining of this tube to reduce friction as you're trying to push blood through it. So that simple squamous epithelium, reduce friction. Myocardium, the myocardium, the middle layer is cardiac muscle. And then maybe a little semicolon, contractile layer. And then the epicardium, areolar connective tissue or just connective tissue. And then like a little semicolon, protect the heart from friction or rubbing, and secure blood vessels and nerves. The outside connective tissue of virtually every single organ functions or performs the same function. Since most organs like the stomach and the lungs and the heart, they need to be able to stretch and then compress back again, means that they're generally rubbing against an adjacent or neighboring organ or bone or spine or rib or something. So the outer connective tissue helps protect what's called the parenchymal areas, the working tissue of that organ, from rubbing against an adjacent organ. But it also, virtually every organ has other blood vessels attaching to it and nerves often attaching to it. So it helps secure them so they don't get, pulled away. And so the epicardium is composed of a connective tissue layer, that protects, the organ from rubbing against an adjacent organ, helps secure blood vessels and nerves supplying that organ. Okay, then we need to trace blood through the heart. Blood begins 3 different origins. All deoxygenated blood returns to the right side of the heart via blue vessels. That's why virtually everything on the blue side of the heart is indicated in the blue color, because of its rich carbon dioxide layer and level. So the 3 sources are the 3 major highways in: superior vena cava, inferior vena cava, and the coronary sinus. So you can put SVC here if you want, but know that SVC, means superior vena cava, inferior vena cava, IVC, and the CS, the coronary sinus. All right, then blood enters into the right atrium, passes through the tricuspid valve into the right ventricle. All right, from there, from the right ventricle, next line, it passes through the pulmonary valve to the pulmonary trunk. All right, so the next, after the pulmonary valve, we have the pulmonary trunk, next line to fill in. Now, the pulmonary trunk is a big vessel leaving the right ventricle, and it splits or bifurcates into a right pulmonary artery and a left pulmonary artery, and out to the lungs. So the lungs are going to be, that next line to fill in. And at the lungs, we drop off carbon dioxide, pick up oxygen, and we return via right and left pulmonary veins to the left atrium. From the left atrium, we pass through the mitral and bicuspid valve to the left ventricle. And from the left ventricle, we pass through the aortic valve to the aorta. All right, what are the first branches off the aorta? Right and left coronary arteries. Right and left coronary arteries. The first branches are carrying the best oxygenated blood, immediately supply the heart muscle itself, the right and left coronary arteries. And then the arch of the aorta is where the aorta takes kind of a hairpin turn and heads inferiorly through the thoracic cavity. It's called the arch. And there are 3 blood vessels, branching off that are cut kind of short on this model, but you'll see them more next week on our big models. So the first branch is the brachiocephalic artery. The second branch is the left common carotid artery. And the third branch is the left subclavian artery. The left subclavian artery. And we will see that on models in just a moment. Okay, now we will move on to the cardiac muscle histology. You need to be able to, if you see a slide and you're asked what identify this tissue, cardiac muscle. If they're pointing to an oval dark staining structure, it's the nucleus. And what does the nucleus do? It houses genetic information. But then we have the intercalated discs. And like skeletal muscle, we have striations, so does cardiac muscle. But where you see an extra thick, kind of striation, it's called an intercalated disc. It's where one cardiac muscle cell connects to another cardiac muscle cell. So intercalated discs are composed of desmosomes and gap junctions. Composed of desmosomes and gap junctions. Those are types of cell adhesions that we looked at in A&P1. So a gap junction, is kind of a pore opening connecting one, cytoplasm of one cell to another. Looks like a little tube connecting one cell to another. And a desmosome is like a spot weld where you can adhese the cells together intermittently, kind of like buttons in a sweater, or in a jacket. You have these extra strong adhesions. So intercalated discs act as desmosomes and gap junctions. All right, then we look at the cardiac conduction system. This is the way an impulse that originates at the sinoatrial node will travel through the atria and to the septum of the ventricles and to the ventricles. So this pathway begins at the sinoatrial node. Now, and that is considered the pacemaker of the heart. It's here at the SA node, you will either be stimulated by the sympathetic or parasympathetic autonomic nervous systems, correct? Parasympathetic system slows down the heart and conserves energy. Sympathetic system speeds up the heart. So the pathway begins at the sinoatrial node, which is in the right atrium. Sinoatrial node, pacemaker of the heart. All right, then we have the AV node. From the sinoatrial node, the impulse travels along what's called internodal pathways to the AV node, atrioventricular node. And from here, it kind of slows down, this impulse and then lets it pass to the AV bundle or the bundle of His. Passes then to the right and left bundle branches, which are within the ventricular septum. So here we're looking at this image. We're starting at the sino, the SA node or the sinus node. The impulse travels to the AV node, right, via those internodal pathways. Then through the AV bundle or the bundle of His. I still refer to it as a bundle of His. And now you're in the septum, which is the walls between the right and left ventricles. And right there, it branches off to what will be the right bundle branch, which will supply the right ventricle, and a left bundle branch, which will supply the left ventricle. So we're in the septum. We have a right bundle branch destined for the right side, the right ventricle, the left for the left ventricle. And once you get past the apex, you see all those little strings and kind of extensions that look like roots maybe of a tree. Those are the Purkinje fibers. So anything past what's called the apex or the pointy part of the heart, those are Purkinje fibers. So we go SA node to the AV node, bundle of His, right and left bundle branches to the Purkinje fibers. So we're going to identify some of these on the models. Some of them are easy to see, some not so much. As far as functions, I think the only function I really ask you is the SA node. Just know that that's the pacemaker of the heart. Okay, then we're moving on to the EKGs. All right, so the EKG represents the electrical pathway, of these impulses from the SA node to the AV node bundle of His, through the ventricles for the atria to contract and then relax. And as they start to relax, the ventricles contract and then relax. And in doing so, I mean, this is how we pump blood. We don't, the atria contract virtually simultaneously for all intents and purposes at the same time. So the atria contract and they push blood down to the ventricles. And then as they start to relax, the ventricles contract and push blood up into the aorta and the pulmonary trunks at the same time. And then everybody relaxes, and that's one cycle. And when you put sensors on certain locations, either across the chest or on the hands and on the feet and across the chest, each sensor is looking at the way the cardiac muscle depolarizes and then repolarizes and comes back to resting membrane potential. We looked at these in skeletal muscle. We talked about these graded potentials and action potentials. And the action potentials, you had the upward deflection of depolarization, where sodium gates open and then the sodium gate closes, and then the potassium gate finally opens, and then you have repolarization, so you become more negative again, and then the potassium gate closes, and then the sodium potassium pump brings you back to resting membrane potential. Well, that's pretty much the same thing, except for in cardiac muscle, once you start to repolarize, you actually have a calcium gate that opens, which causes the membrane potential to kind of flatline and stabilize for a period of time, and you get that calcium plateau. So as calcium is entering the cell, which is positively charged, you're losing potassium, which is positively charged, and there's really no net difference of voltage charge across the membrane. So it plateaus, and that calcium gate finally closes, and now you see that line drop down, and repolarize the cell, because the only gate left open is the potassium, because it opens and closes very slowly, and it now produces that normal repolarization as you've seen in skeletal muscle. So hopefully you've seen this in lecture, because I don't really have room for it in here, but to kind of keep in mind that each atria has to depolarize, calcium plateau, and then repolarize, and the ventricles are going to do the same thing. And that's because these different ions and these different voltage gates are opening up and ions are passing through them. All right. So one cycle is represented in this electrocardiogram where you have a P, QRS, and a T wave. And then sometimes you have a little U wave down at the end. Right? But don't worry about the U wave right now. So it says, be able to recognize the following events seen in an EKG. Also know what electrical event, depolarization or repolarization, occurs during each wave. All right, so we're going to take this P wave. So we start with, to the left, you have a flat line. You have a P wave, right? And then it kind of flattens. And then you have QRS to a flat line. And then you have your T wave and kind of a flat line. Sometimes you can see a U wave, sometimes you frequently can't. All right, so let's just look at P, QRS, and T. So it's shaded here and telling you what's occurring. During the P wave, we need to look and identify which of these is happening during the P wave. Atrial depolarization, ventricular depolarization, atrial repolarization, ventricular repolarization. Because we know that the atria have to depolarize and contract and then repolarize and go back to resting membrane potential before it can depolarize and repolarize again. During depolarization, or really toward the end of depolarization, is where you had the atria contract and is therefore ejecting blood. And that calcium plateau lets it contract and hold, squeeze, and then relax, repolarize, and relax. And the ventricles go through the same thing. Right? So the P wave represents atrial depolarization. Right? Atrial depolarization, so right next to the P wave. During the QRS wave, we not only allow the atria to relax now and repolarize, but we start to ventricularly contract and go into systole, right? So during the QRS wave, we have atrial repolarization and ventricular depolarization, two things occurring and overlapping. And then in the T wave, we have ventricular repolarization. Now, something we talk about a little bit more in lecture and to keep in mind here as you're looking at all this anatomy, is, when the atria contract, what valves should be open, and what valves should be shutting. Because in here, we will then be able to anticipate where we would see, oopsie doodle, this is kind of where the first heart sounds would be produced and where the second heart sounds would be produced. All right. So the atria contract and hold, that's your P wave. Right. And when the atria are contracting, your tricuspid and mitral valves are open. Right. And your pulmonary and your aortic valves are closed. All right. So they're not making any sense. They're closed. We started this process, with the flat line to the left before the P wave. All right. We have the semilunar valves are closed, right? And as the atria depolarizes, start to contract, they pop open the tricuspid mitral valves and start pushing blood down into the ventricles, all right? So as the ventricles contract in the QRS wave, about at the R point, at the top peak there, that's where you hear your S1 sound. The S1 sound is produced when the ventricles contract and they close the tricuspid and mitral valves. So that's right at the peak of the R wave. The ventricles contract through the S and flatline there where the blue and the pink kind of meet. They contract and hold, and they're pushing blood up into the aorta and the pulmonary trunks. And then they start to relax. And that's the T wave. About the top of the T, where the T is, the top of that T wave is where you hear the S2 sound. S2 sounds are produced when the blood that is pushed up into the aorta and the pulmonary trunk, kind of fall back down again. The ventricles have ejected as much blood as they can up into those big vessels. And when the ventricles start to relax, some of that blood, kind of falls back down on the pulmonary and the aortic valves and force them to shut. And that is the S2 sound. And that is produced about the peak of that T wave, the peak of that T wave. kind of keeping in mind that, so I might over by the S, I just read an S1 sound because that's when that's produced. And the peak of the T, put like an S2 sound there. Maybe just handwrite that in. You know, for me, I like you to know, especially in lecture at least, you know, when these sounds are being produced. Because when you, very soon, you're going to start listening to chest sounds. Hopefully you'll get into your particular program. I know everybody isn't going into nursing, but you need to know why you're listening to S2 sounds, you know, in the aortic, which is technically you're going to listen to it on the right side, even though the aorta, you know, and the aortic valve is on the left side of the heart, and you're going to listen to the pulmonary valves on the, you know, to the left of your sternum at the second intercostal space. You know why you're listening to them where they are, because you know exactly where the heart is positioned in the chest, because it's not straight up and down and in the middle, is it? Right. So you need to know where it's rotating to, and then you need to understand that the aortic area, intercostal space to the right, second intercostal space to the right of the sternum is where you hear the aortic valve closing. Pulmonary valve is on the corresponding left-hand side. You know, you have Erb's point, which is where you hear all the valves closing at the same intensity. And then just to the immediate left of the sternum, about the fifth intercostal space, you know, is where you hear your tricuspid valve, and rotate a little bit toward your armpit along that same intercostal space, arguably, is where you hear your mitral valve closing. And so once you know the anatomy of heart, then you know where to listen for the heart sounds. All right, so where does atrial repolarization occur? It occurs during the QRS complex. Now, the shape of that QRS is really due to the impulses traveling to the ventricles, because the ventricular walls are very thick, right? And they're much thicker than the atria. So even though the atria are repolarizing it, it's way overshadowed by the electrical events of the ventricles. And so the shape of that QRS is really reflecting what's happening, the impulse normally passing through the ventricular walls, you know, not the repolarization of the atria. But ventricular repolarization, there's only one physiological event occurring during that time. And so that T wave does represent, you know, quite accurately the repolarization of the ventricles. Okay, so sample EKGs, when we look at sample EKGs, and we will be able to identify them, what is a normal sinus rhythm, sinus bradycardia, tachycardia, a couple abnormal strips for atrial flutter, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation should be in there as well. Oh yes, it goes on to the next page. Ventricular fibrillation and AV block. It just happened to break funny there. So don't stop at the bottom of page 3. Go on to the next one, because there's more. Okay, so before we move on, we're going to identify normal sinus rhythm. Okay, so a normal heart rate is, well, you know, kind of depends sometimes on your textbook, but 60 to 100 is, I believe, what the nurses are using. 60 to 100 is a normal sinus rhythm. Bradycardia, brady means slow, so a lower or slower heart rate would be less than 60 beats per minute. And sinus tachycardia would be higher than normal heart rate. That would be heart rate above 100 beats per minute. Now, you will have a normal QRS and T. You just either see them spread out along a 6-second, you know, sheet. You know, you'll have a little strip of EKG paper that represents 6 seconds, and depending on how many full cycles or fractions of a cycle you see, because you're going to count generally your R waves that you see, you know, is count how many of these cycles, or maybe, you know, that you see in this 6 seconds that is occurring, and then you multiply that by 10 to see how many heartbeats are in 60 seconds. If you see only a half of a whole cycle, then you might want to say, hey, that's 6.5 beats, you know, that would be 65 beats per minute. Okay, so a normal sinus rhythm is 60 to 100. Sinus bradycardia is less than 60 beats per minute. Tachycardia is heart rate in excess of 100 beats per minute. You can see that on EKG strip. And then we will look at what is atrial flutter, atrial fibrillation, ventricular tachycardia, ventricular fibrillation, and AV block. And really all you have to do is identify the strip for what it is. Okay, so let's now switch to some of the images because that carries the most weight. Let me stop my share and then switch to the images. I just clicked the wrong one. Hold on. Here we go. Okay, so now we are here under lab 2. Again, we find the lab guides under lab guides. So that way you can print them all out at once, or you can do 4 at a time. Then we go to lab 1 and lab 2. So we're in lab 2, all right, lab 2, heart lab notes. Here are the EKG strips. I'm going to go back to those at the end. And I'm first going to go through all the images and identify all the anatomy, which it does really on your own. But here, let me move this thing out of the way. All right, so here's image number 1. We're pointing to different layers. We have the outer layer, which is number 1, the middle layer, the thick intermediate layer, which is number 2 and 3. Right, so the outer layer would be the epicardium, middle layer myocardium, inner layer endocardium, epicardium, myocardium, endocardium. Now, I want you to know what tissues and the function of those tissues are that are found in each layer. So we said the endocardium is simple squamous epithelium, reduced friction. 2, myocardium would be cardiac muscle, contractile layer. Epicardium, connective tissue or areolar connective tissue. Protect from rubbing, secure blood vessels and nerves to the structure. And so I can point to 2 and say, identify the tissue found at 2, at layer 2 or at 2. Cardiac muscle. Okay, now we're looking at chambers, right? So we're like looking at the front of somebody, right? So the 1 and the blue structures here over, where 1 and 2 is actually the right side of the heart, and 3 and 4 are pointing to the left side of the heart. So picture, the heart sitting in your chest, right? The blue number 1 and 2 would be on your right side, pointing toward your sternum, and 3 and 4 would be the left side. So we have right atrium, right ventricle, left atrium, left ventricle. Now we're looking at valves. We're 2 and 1. We're still on the right-hand side because you see how everything is blue on that side? The blue vessel to the top, the blue atrium, the blue pulmonary trunk, just above 1. It tells you you're on the right-hand side. Okay, so we have valve number 2, which is between, did I say left before? If I did, I'm sorry. The right atrium and the right ventricle. That's your tricuspid valve, the flat parts of the plastic there. That's the valve part. That's the tricuspid valve. And from the right ventricle to the pulmonary trunk are the pulmonary valves or the pulmonary semilunar valves. All right, so it's pointing to the 2 valves. Right, pulmonary semilunar valve, and then the tricuspid valve. Now, the general function of valves is to prevent backflow, right? To prevent backflow. Attached to each, and hopefully there's a better picture farther on. Let's go back and I'll show you. I'm certain there's a better picture as we progress forward. All right, so the flat parts of white up there is the valve itself. Do you see these white strings? Kind of looks like, it's like a parachute almost, but you have these white strings, right? Those are the chordae tendineae. And at the base of those, the red, that is attaching to the endocardium here, those are what's called papillary muscles. Papillary muscles are extension of the cardiac muscle. They attach to the chordae tendineae, which attach to the valves. And they put tension on those valves to keep them from flipping like inside out, like a cheap umbrella when the wind gusts. All right, so the chordae tendineae is a white stringy part, and the red bumps at the base of it are the papillary muscles. Here's even a better view. I knew there was another view coming up. All right, so now we're looking, at the other side of the heart, on the left side of the heart. So on the left side of the heart, we would have the tricuspid or mitral valve, which is number 1. And then from the left ventricle, which number 2 is sitting in, you'd have the aortic valve that leads to the aorta. This gives you a really good picture of that chordae tendineae, the white strings, and the red at the base of that. That would be the papillary muscles. Okay, now we're looking and we're identifying the sources of blood back to the heart. So here we're looking at a lot of blue, so that's got to be the right side, all right? And we're looking at sort of from your right shoulder toward your chest. Right? So here we have, and 1 is on the superior aspect and 2 is on the inferior aspect. These are the 2 major vessels, and then there's a third. We just have to rotate the heart model that show where blood is traveling from peripheral circulation to coronary circulation through the heart. So this is part of that blood pathway. We said there were 3 sources of deoxygenated blood, that's the pathway through the heart. This is the first 2. Right, so we have 1 is the superior vena cava, 2 is the inferior vena cava. And that big bubble there, that's the right atrium. Right? So we have superior vena cava and inferior vena cava. And then on the back side of the heart, we have this large blue vessel here, 27. Well, 3 is pointing to 27. That is where multiple small coronary veins, which are like the little, like you see where 60 is right there, that little blue vessel, right? Those small blues, they do have specific names, but you don't have to know them. The blue ones are coronary veins, and the smaller red ones, like adjacent to it, number 61, are coronary arteries. Do they have specific names? Yes, but you don't have to know them. Well, where these coronary veins, like 60, all merge together, transporting deoxygenated blood back to the heart, merge into 27, which is a big vein. It's like all these smaller veins from your abdomen merge to form the inferior vena cava. So they all have to end up forming, and merging into one big highway into the heart. And that's the coronary sinus. Right. Over to the right, number 26, that's your inferior vena cava. But 3 is pointing to that dilated vein here that is transporting deoxygenated blood from coronary circulation. That's the coronary sinus. Right. The thick part is the coronary sinus. Right. You'd have to point to one of those little skinny ones for a coronary vein, or that's what I would do anyway. Okay, now we're identifying vessels here. So we're looking at a great big blue thing. So that means we're still deoxygenated blood. We're in carbon dioxide, right? So we are again looking right at the heart. 1 is pointing to, essentially coming from the right ventricle. So that the right side and then the left side. So 1 is pointing to the pulmonary trunk. And it's going to split, like I said, to branch off into pulmonary arteries. Now, mind you, this blue, but we have to call it pulmonary artery because technically it's transporting blood away from the heart. So this is one of the exceptions that all arteries are blue and veins are red. This artery is still blue. So this is pulmonary trunk, and it's going to branch off into a right pulmonary artery, which is 3, and a left pulmonary artery, which is 2. So it's going to branch off to go to the right lung and the left lung and drop off all that carbon dioxide. and the card's upside down and I'm unable to rotate it. But you have pulmonary trunk, left pulmonary artery, and the right pulmonary artery. I don't know how we got it upside down, but anyway. All right, next one. See, lots of identify. This is easy stuff for you guys. All right, so now we're looking again right at someone's chest. Blue, where number 1 is, that's the right side of the heart. Where 2 is pointing to is the left side of the heart. So traveling back from the lungs are going to be pulmonary veins, but the veins are going to be red. So if we could rotate the heart a little bit more, kind of counterclockwise here, you would see the 2 pulmonary veins, 2 red things, which is number 1 is pointing to. This picture might get turned around again. And 2 is pointing to the left pulmonary veins. They connect to that big chamber here where 7 is, so to speak, to the left atrium. So point 1 is pointing to the right pulmonary veins, 2 to the left pulmonary veins from the left lung coming back to the left side of the heart. And 3, here we have the big aorta, where you have the first branches off the aorta, which it's hard to see the number, but I think it's 28, and then 29 is just above the Dr. Reitman's thumb here. Those are the right and left coronary arteries. They're the first branches off the big aorta here, which is number 11, that big aorta. And then 13, 14, 15 are those 3 branches off the aorta. But we'll come back to that. So there's a lot on here. Right pulmonary vein, left pulmonary vein, the aorta. And it's upside down. So I don't know what happened to his pictures when he uploaded them. But okay, so this is trying to point to the right and left coronary arteries, as I described before. So if this was rotated, the 1 is pointing to the right coronary artery. 2 is 3 and 4 are pointing to the branches of the aortic arch. 2 is the brachiocephalic artery, 3 is the left common carotid artery, and 4 is the left subclavian artery. Let's just, I think it'd be maybe easier if we just go back 2 pictures and let me show you here, because it's right side up. So above 3 is 13, 14, and 15. So 13 would be the brachiocephalic artery, 14 would be the left common carotid artery, and 15 would be the left subclavian artery. And if you could maybe identify the right and left coronary arteries down in the bottom. Some people print these out and it gives you the opportunity to kind of take put a little piece of masking tape on it, perhaps, or something that you could peel on and off if you want and label it that way. That might work. Okay, moving on. Label, label, label. Okay, so now that helps you identify the pathway of blood through the heart. You looked at all the different anatomy. We looked at every valve. We looked at chordae tendineae and papillary muscles that attach to the tricuspid and mitral valves. We looked at layers of the heart. We looked at the source, the superior vena cava, inferior vena cava, coronary sinus to the right atrium, tricuspid valve to the right ventricle, from the right ventricle to the pulmonary valve to the pulmonary trunk to the right and left pulmonary arteries, out to the lungs, drop off carbon dioxide, pick up oxygen, come back via the pulmonary veins, which are red. You have a pair to the right and to the left atrium, through the bicuspid or mitral valve to the left ventricle, from the left ventricle through the aortic valve to the aorta. You immediately have right and left coronary arteries peeling off there. You go to the aortic arch and you have 3 vessels: brachiocephalic artery, left common carotid artery, left subclavian artery. Okay, here's the histology. This is a really nice picture of cardiac muscle tissue, where you can see all those lighter striations like you see in skeletal muscle, but then you can see these extra heavy ones And the pointer there is pointing to one, that extra heavy little line, and they're scattered throughout. You can see them intermittently, right? Those are the intercalated discs. They function as a gap junction and desmosome. And then the nuclei are those large dark staining ovals. They're pretty easy to see. Contains genetic material. That's fine. Okay. Cardiac muscle tissue, myocardium, intercalated discs, blah, blah, blah. Yeah. Okay. We're looking at the conduction system now. So we said that we start with the SA node to these internodal tracts, and internodal tracts are very, very rarely even identified, on any of these models, but it does point to an SA node and an AV node. SA node is the pacemaker of the heart. That's fine. That's where your sympathetic and parasympathetic fibers will communicate with the heart. That's why you need to have connective tissue there to keep those nerves nicely anchored. Sympathetic effect is going to increase heart rate. Parasympathetic is going to decrease heart rate. Might be good to note in there that sympathetic nervous system uses norepinephrine. Parasympathetic division uses acetylcholine. Okay, then we can see where number 1 is, really where 38 is. You have, the bundle of His kind of right behind it. And then you can see, because we're looking at the right side of the heart, because you see all those that blue chamber, right? And here we have the ventricular septum is the wall between the right and left ventricles, right? Is that if we're looking into the right ventricle, then 2 is pointing to the right bundle branch. And then the little branches down here, 3, he's pointing to, and even the smaller branches off there, emanating off the right bundle branch are Purkinje fibers. Right, so the bundle branch is under number 1, right? And then you have the right bundle branch specifically. If we looked into the left ventricle, we would see the white lines on the septum, and those would be the left bundle branches. And then the Purkinje fibers. All right, we're looking at a little EKG that's handwritten out here, a P, Q, R, S, and T. Right? What's happening functionally during each part of that wave? Right, we have atrial depolarization in number 1, 2, which is the QRS wave that has atrial repolarization and ventricular depolarization, and then 3 represents the T wave, ventricular repolarization only. So P wave, QRS complex, T wave. Here we have some samples. I also put them up individually as EKG waves so you can print them out. But here we have each strip labeled as 1 and 2. Right? 1 here, it says the QRS rate is 60 to 100 beats per minute. So if that's a normal sinus rhythm, right? We have a P, QRST. Kind of start on the left and work your way right. And you actually have technically a piece of a T wave over here, but then you have a flat line. Right? So we're way over on the left-hand side. You have a P, P, QRST with a little flat line, P, QRST, P, QRST. And so if we count the number of full cycles that we see, 1, 2, 3, 4, 5, 6, 7, 8, that's 8 because you don't quite have the T wave here, and that's the T wave. I'd say if someone asked you to calculate the heart rate, I would say it's 80. If I see 8 full cycles in 6 seconds, then to find out how many are in 60 seconds, you have to multiply it by 10. All right, so it's within 60 to 100. It's a normal sinus rhythm. Now down below here, without looking at the little strip there that tells you what the heart rate is or what it is, try just counting the cycles that you see. So go over to the left-hand side You have a little flat line, then you have PQRST, long flat line, PQRST, long flat. Yeah, it's a normal wave, but we have 1, 2, 3, 4, 5 cycles that we see. So 5 times 10 is 50, which means it's a, and normal is 60 to 100 beats per minute. This is only 50 beats per minute. Then it would represent bradycardia. All right, it's below 60. And normal sinus rhythm, and then abnormal sinus rhythm. Then we have the one on the top here. All right, we have a normal rhythm. We have a normal PQRST, PQRST. But if you count them all up, it's going to produce tachycardia. Let me see, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 and a half. So it's about 110, give or take, beats per minute. Well, anything over 100 is tachycardia. And take a good look at it, because even though these, you have them compressed, you have a PQRST, a PQRST. It's important to understand that. Right? Because when they get compressed like that, it's easy to say, hey, maybe those are multiple P waves. No, they're not. You start from the left and work your way right. Now, number 4 is showing that. So here we have, if we start on the left, we kind of don't see a P, but we see a QRS with a T. Right? Then we have a wave and a wave, like 2 P waves, and then a QRS T, wave, wave, QRST, wave, wave. Those are 2 P waves. And that's called atrial flutter. And so we have sinus tachycardia, and then we have atrial flutter. Okay, then we have strips 1 and 2 here. So let's look at that, because it's giving you, it says no discernible P wave. All right, and that's correct. So let's start over on the left. We have, it's probably a P wave. We have a QRS and a T. And then we have, it looks like you're taking a lie detector test. It's like you said, the needle's going up and down. And then a QRS and a T. Needle goes up and down. We have multiple P waves of varying heights here. Now, the previous atrial flutter, if you notice, the height of the P wave is pretty much the same. All right, when we have these 2 waves down here, where number 4 is, we have a T wave, and we have 2 P waves followed by a QRS. You see how they're about the same height or amplitude? They're virtually the same size, the same height, upward deflection. Versus here, atrial flutter is you have multiple skipping heights, right? They're not 2 nice little peaks. It's varying heights. That's atrial flutter. Okay. Then we have 2 strip here. Right. We have, starting over the left, we have a QRS with a T, and then a P wave, and kind of a long flat line here between P and the QRS and the T. And then you have a P wave and a flat line. Ooh, a long flat line. Like, look, it never even produced a QRS or a T. And then we have a little P wave, QRS with a T. That looks like a normal one, but we dropped something here. When you have those drops like that, where you have, and especially where you have a P followed by a pretty good, an extended flat line, isoelectric line before your QRS complex like that, it means that the impulse is traveling rather slowly, difficult, from the atria to the ventricles. Right, so it's not surprising that the next time it tries to pass through there, it never even does. Right, so you have that long flat line just below, like the left end of the 2 arrow, go straight down. You have that nice flat line there. That's where you drop the ventricular contraction. And you can see another long one over there. So the top one is atrial flutter. Number 2 represents an AV block of different degrees. You can have, 1, 2, and 3 degrees of AV block. And then we had the ventricular pathologies. All right, this one at the top where you have it looks like ribbon candy. You can't see any discernible normal QRS T wave. And when that happens, it means there is something seriously wrong with the ventricles, because when you have electrical dysfunction, so to speak, between the ventricles and those walls are really thick, it overshadows any normal electrical event that might be happening in the atria. Right, so all you see the needle doing is really representing what's going on in the ventricles. So when you have this same kind of height of each wave, up and down and up and down and up and down, like a sinus wave in physics, that is ventricular tachycardia. Below that, where you have, again, no real discernible or recognizable QRS complex, it's ventricular something, right? When they're all of the same height, pretty much, like in number 3, that's ventricular tachycardia. Just the ventricles are contracting normally, so to speak, but they're just contracting very, very rapidly without a resting phase in between. 4 represents ventricular fibrillation. Varying heights and amplitudes of ventricular contraction. Ventricular fibrillation occurs when, instead of the entire wall of the atria or the walls of the ventricles getting this signal to contract all at once, and they all contract down and squeeze and hold, and then all relax, one side of the wall, like the anterior aspect of the ventricle is contracting, and then as it starts to relax, finally the impulse gets to the back wall of the ventricle and it starts to contract, and then it starts to relax, and maybe the lateral wall now contracts. It's not contracting in unison and squeezing down and ejecting blood, just different walls. It's kind of like looking at jellyfish kind of, on the beach, it's just kind of jiggling back and forth, and different walls are going through, or areas of the ventricular wall are going through depolarization, repolarization, but not as a unit and effectively. And that's what generally ventricular fibrillation or fibrillation is in the ventricles or the aorta, the atria. Okay, so that's all our images. If you have questions, shoot me an email. All right. Your quizzes are due this Sunday. This is the summer class. So you have 2 labs this week and quizzes are due this Sunday. Make sure you check the calendar and you check your schedule. If I made a boo-boo someplace, just let me know, right? Because I can always correct it, but you have about 15 minutes to 20 minutes. So I think 20 minutes for your quizzes, 1 attempt, get in there and get it done. All right, that's the end of the Zoom. Bye.